This was a presentation given by Dr. Joe Veltmann on August 28, 2014, before 250 medical doctors in Guadalajara, Mexico, as part of a seminar entitled Using Genomic Testing to Improve Patient Outcomes. It is a pleasure to be here this evening to share this new and exciting information on BRAC1 and BRAC2 genes and ER-positive breast cancer, and more importantly, how genomic testing and appropriate interpretation of those genomic results can lead to improved patient outcomes. Let me first present the learning objectives for this slide presentation. We're going to differentiate between BRAC1 and BRAC2 breast cancer, which, as all of you know, is the inherited form of this disease, versus ER-positive breast cancer, which is triggered by estrogen or its metabolites. Second, I will discuss the biochemical mechanisms behind each of these diseases, and then springboard into a discussion of how functional genomic testing can be used to individualize treatment strategies for each of these breast type populations. I'll then share with you my clinical experience with a woman diagnosed with ER-positive breast cancer and follow her through her genomic testing, nutrigenomic strategies, and biomarker testing. I'm pleased to report that she is cancer-free more than 10 years post her diagnosis. With all the publicity about Angelina Jolie's recent BRCA1 and BRCA2 diagnosis and her decision to have both a bilateral mastectomy and ovaries removed, you would think that this type of breast cancer is the most prevalent, but it actually only accounts for between 10 and 15% of all breast cancer. A fact that you might have missed in a recent survey of a Toronto hospital showed a twofold increase in the number of women wanting to get screened for BRCA1 and BRCA2 genes during the 6 months after Angelina Jolie's announcement. However, the incidence rate did not significantly increase among the women tested. This illustrates to me the power of celebrity and the media to bring attention to important health issues like breast cancer. As this story illustrates, any publicity about breast cancer can lead to early detection and better patient outcomes. However, I spend a lot of my clinical time educating women about the difference between BRCA1 and BRCA2 breast cancer and ER-positive breast cancer, which may also happen to be in your clinical practices. For the record, ER-positive breast cancer comprises about 75 to 80% of all breast cancer diagnosed in the U.S. To put it in real numbers, more than 200,000 women each year are diagnosed with ER-positive breast cancer, whereas between 14,000 and 19,000 women are diagnosed with BRCA1 and BRCA2 breast cancer. I was interested in knowing how the breast cancer rate and mortality associated with the disease differs for Mexico and other Latin American countries versus the U.S. According to a recent review published in 2013, except for Uruguay, which has a breast cancer rate that even exceeds the U.S., the rate of breast cancer in Mexico and other Latin American countries is significantly less than that found in the U.S. There are a lot of reasons for this, which we don't have time to present in this presentation, but suffice to say, by the year 2030, the number of breast cancer deaths in Latin America will double to 74,000, twice as many as those reported in 2008, simply because the number of women 60 years of age or older will increase twofold. For most of us, we were taught in medical or graduate school that mutations in the BRCA1 and BRCA2 genes resulted in impaired DNA repair, leading to rampant cell division, and therefore these genes had tumor suppressor function. We are finding out other truly amazing things about these genes, which I'll be sharing with you shortly. Nevertheless, the disease is catastrophic to women diagnosed with BRCA1 or BRCA2, because the lifelong risk of breast cancer is greater than 87% and the risk of ovarian cancer is 44%. A BRCA2 diagnosis is much less, with only a 7% lifelong risk of breast cancer and a 25% risk of ovarian cancer. In men, there is a reduced risk of male breast cancer when diagnosed with BR BRAC1 versus BRAC2. As you might imagine, the cancer risk in the second breast in women is increased in BRCA1 diagnosis. As we know, BRCA1 and BRCA2 genetic mutations are not just limited to either the breast or ovarian tissue, and the penetrance of these genes in women is found in other reproductive tissues like the cervix and uterus, along with the pancreas, colon, stomach, gallbladder, bile duct, and even skin cancer. In men, the profile is very similar.